is now busy with the Facebook Live.
Hope he sees the message.
So the other people who are assisting him, the event manager or whatever it is called, they are also not seeing.
Yeah, this is
It is not flashing. They are possibly they are seeing the program right now, but program should be seen from the mobile. Is better when you are in front of the.
but I think it should be seeing the messages.
Not saying it. Ashokan has joined. Hi Ashokan, good morning.
Now Vivek, Prakash, Deedwania, Ashokan is muted.
No, Ashokan has just unmuted himself. Good morning, Ashokan.
Morning, morning,
Yeah.
Hi, how
How
are
are
you?
you?
morning.
What's going on?
Ashokan, you'll have to train Vivek Gupta to maintain the time.
Dr. Das, we have to learn so many things, although despite doing so many conferences, there's always a time lag of 15 minutes. So thank you very much for joining in. And we'll just show you a small video before we start, just to introduce. Am I audible? Can you see me?
Gupta, you are muted.
Mute, अच्छा म्यूट कर रखा हमको कैसे? Can you hear me now? But I want to see the faces of the Zoom people on the screen. I'm just because it's the first we are requesting the audiovisual people. Dr. Deedwania, this is the first time you are joining for our conference. The conference we started in 2008. Um, uh, uh, that was with Dr. Alan Kribier, myself as course director, and Dr. Kribier also as course director. That was January 4, 5, 6 in Vigyan Bhavan in Delhi, and also one last day in the hotel. So that was a very extremely important conference, and I want to share the slides of that. Was just 5 minutes introduction. Who you have taken the just 5 minutes introductions about the conference. So this is the small video which I want to show you. This was actually a conference in Paris. I always love to show this. We did in 2009.
He suggests
Can you see, Dr. Deedwania, can you see our screen? This is not visible to them. Yes. Can you hear us? Can you hear the video? This is Dr. Sigvard speaking along with Dr. Greg Stone. Can you see the screen? So this was held in the Georges Pompidou Hospital in Paris with Dr. Cribier and many doctors from India presenting the case. This is Dr. Alan Cribier. The video is, I think, something wrong with the video. Okay, so I skip this video now and go back to one slide presentation before you start the talk, heart failure.
Dr. Vivek Gupta,
Yeah.
you give the lecture of mine after Dr. Deedwania, there will be a continuation. Because in the program I see
That is the wrong sequence. Dr. Vivek Kumar will speak later on. Yes, I agree with that. Mr. Rishabh, can you stay with me? So I think we can start the talk. We will show the later to the audience about the conferences जो कल आपने बनाया था वो कहाँ है इसमें स्लाइड बनाई थी ना कॉन्फ्रेंस के बारे में
किसमें कॉपी करी है ये सर IECR शेड्यूल PPT नहीं डॉक्टर
So this is actually, can you see the slide? So Indo European Course on Revascularization, we started in 2008 and I could get this brochure which was on their website, and therefore I downloaded the first Indo European course with Dr. Cribier and myself and other people. And there were, ICR meeting was in Vigyan Bhavan with 15 live transmissions at that time. So I always feel proud to say that the time of 2008 in India, we had CSI, we had NIC, we had Indian College of Cardiology, and there was no other major cardiology conference. India Live and other conferences they started later. So at that time, it was an idea with Dr. Cribier to start a conference here. And at that time, we also had a TAVI symposium. International faculty included Dr. Cribier, Hélène Elshanov, Martin Gillard, Dr. Bernard Chevalier from France, Dr. Pichard, and many others from USA. The first live transmission from all major cardiology center of India, Dr. Bernardo Cort from Italy and Dr. Fayaz Shawl, Dr. Greg Stone, they all spoke from US, that was online. The chief guest was Chief Minister, Mrs. Sheila Dikshit, and the further courses were held in universities of London, Paris, Amsterdam, Rome, and Zurich, and later in India. This is the 21st edition of the ICR, which is being held in Delhi now. And the next course will be held with academic collaboration with the Institute of Andaman and Nicobar Islands in Port Blair in the March 1 and 2. That will be much better planned than this one. Actually, everything is fine except that so this conference today, what we are going to show, will be having lectures from the first will be heart failure session, and then that will be followed by coronary artery disease, mitral valve symposium session, coronary artery disease symposium, and after that there will be aortic valve intervention, there will be coronary intervention, and then it will be valedictory function. So it's a packed program with more than 25-30 lectures and some live inbox by Praveen Chandra from Medanta Hospital. He will be joining here. I think now we go on to the session, which will be a session on heart failure after the small introduction about this conference. And I have to introduce my very senior colleague, Dr. Prakash Didwania, who's who is from US, Indian origin, but he has a huge experience of having a Doctor. Can you show Dr. Didwania now? Huge experience of heart failure, other clinical cardiology. I've been meeting him for almost 2 decades or 3 decades in various conferences, and I am very obliged to see that despite having almost 12 midnight in US, he's agreed to give a talk. It will be chaired by Dr. Vanda, who will be just joining in, Dr. Mukesh Goel, who will be talking about the heart failure surgical part, and many others. This conference is continuously on Facebook Live and YouTube Live. This is sort of a hybrid meeting with Zoom connectivity, and many people will join through the Zoom. We already have doctors early morning in December on Sunday, and the last Sunday of December, and people are a little more lazy than, of course, in fact, including myself. So we'll have a crowd. I'm quite sure that we'll have a crowd by the 11 a.m. or 10 or 11:30 with the coffee break. And so after my brief introduction, I request Dr. Didwania to start his talk on heart failure. Heart failure is a very important and serious condition because it has got a mortality and morbidity associated. Number of patients of heart failure is increasing day by day. For the people on the Facebook Live who are not medical people, I would like to say it is not there is a huge difference between the cardiac arrest and the heart failure. Heart failure means there is a ejection fraction, which is preserved ejection fraction or a reduced ejection fraction, two types. The rest I will leave with Dr. Prakash Didwania to speak about this important topic. And this is, I want to tell you that this will be Facebook Live, and then recurring, it will be going and seen by many people, and will be also on Instagram Live. So the number of people in the hall does not matter because it will be actually being seen by many people later on, and we'll have each lecture separately dedicated, will be on again on various social media, so that people can have a watch later on and learn, educate, learn, treat, and teach and treat. This is the motto of IECR. Thank you, Dr. M.K. Das. Once again, I request Dr. Prakash Didwania, and then later on, I will introduce Dr. M.K. Das regarding because he has a huge credential to his credit. Okay, so we go on. I leave this place for Dr. Deedwania to start with the contemporary approach in heart failure 2024 and beyond. It's a very comprehensive topic he's going to talk about. Please go ahead, Dr. Prakash Deedwania.
Thank you very much, Vivek. It's my pleasure to share my experience with heart failure, which I've been involved in various studies and using the heart failure approaches for the last 40 years. I'm director of heart failure program here at UCSF and professor of medicine. I think Vivek rightfully said that heart failure is a major public health problem. As a matter of fact, it's a public health emergency. It is expected that number of patients with heart failure at the present time is in excess of 70 million people that are living with heart failure, and this number will increase exponentially. In US alone, it's expected that there will be 46% increase in Americans that are living with heart failure in the next 5 years. What is very important is that heart failure is worse than many cancers. 50% of patients with heart failure, once they develop the symptoms, if not treated
Dr. Vanda
properly,
Bagga, I may request you to be on the stage for the chairing this session. She's the Director Health Services, Delhi government. Okay, Dr. Prakash, please go ahead, please.
Another important thing to keep in mind is that there is significant healthcare cost burden with heart failure. It is expected that this cost of heart failure care will increase by 60 to 70% throughout the world. In America alone, this is resulting to about $70 billion per year. Now, what is very important to keep in mind is that heart failure, once it ensues, it's a downhill path all the way. Once the heart failure is onset, and then the patient is hospitalized, each hospitalization, their prognosis is worse until such point that they get very, very advanced heart failure and eventually die if not properly taken care of. Now, let me say a few words about heart failure in South Asians or Indian. Burden of heart failure in South Asian is very high as well. Unfortunately, we don't have very good reliable data about the incidence and prevalence of heart failure in people in India, and these data are lacking and much, much more needs to be done. Also, there is lack of standardization of the definition of heart failure in India. based on the disease-specific estimate, prevalence of heart failure is in several millions and it's constantly increasing. The reason heart failure is increasing is because there is higher prevalence of CAD amongst the population at large. More people with MI are living now because of successful primary angioplasty or post-MI care. Overall, people are living longer, so with increased life expectancy, we must keep in mind that heart failure is a disease of the elderly, and clearly, number of elderly people are increasing, and it was approximately 115 million people over 60 years of age in 2016, but I'm sure that number has gone up and is supposed to be in the tune of about 130, 140 million. Many people have hypertension that is recognized as a disease. More than 200 million people will have hypertension by the end of next year. Increased incidence of diabetes. We are all well aware of the tsunami of obesity and diabetes in India. Now let me just begin talking about where we were in heart failure, where we are and where we are going. Heart failure in the 80s was very poorly defined in terms of its pathophysiology, very high mortality, as I mentioned, worse than many cancers, and there was no well-defined therapy. So we were using predominantly stage diuretic and vasodilators. Patients were hospitalized again and again, and their quality of life was quite compromised. Much has changed now. In the recent times, now we know that heart failure is a multi-system disorder. It's not just a mechanical problem with cardiac dysfunction leading to fatigue and poor exercise capacity, but it's also a renal problem because the activation of renin-angiotensin-aldosterone system, which causes sodium and water retention. It's a structural problem associated with LV dysfunction, LV dilatation and remodeling. It's also a vascular problem because heart failure is associated with dysfunction, and it's a endocrine problem. Actually, there is very few systemic disorders that we are aware of that causes so much neurohormonal perturbations as heart failure. Now, this is a synopsis of what heart failure is all about. Heart failure begins with some kind of myocardial injury or induction. It could be injury due to infarction. It could be pressure-induced left ventricular hypertrophy. It could be cardiotoxic drug. It could be cancer, etc. That causes changes in molecular biodynamics and altered cellular responses, which causes the process of LV remodeling and anatomical alterations as well. All of these then lead to cardiac dysfunction. It is the onset of this cardiac dysfunction that causes the circulatory perturbations, that is increased afterload, increased preload, and these physiological responses initially may be adaptive, but eventually they'll be maladaptive, and then this asymptomatic LV dysfunction leads to acute heart failure, pulmonary edema, etc. When we talk about the risk factor of heart failure, of course we blame coronary artery disease, etc., but we must not forget that hypertension is the single most important etiology for heart failure in the population at large. Very important to keep in mind, because if we properly treat hypertension, we can basically avoid failure. Diabetes is emerging, and of course, most diabetic patients have hypertension, which could then be related to the double whammy effect. And patients who have hypertension and diabetes are at high risk of having coronary heart disease, which also then will be responsible for LV dysfunction. In addition to that, we have emerging risk factors such as obesity, insulin resistance, metabolic syndrome, chronic kidney disease, which is present now if carefully for in 1/3 of the population, familial cardiomyopathy, viral cardiomyopathy, and of course COVID-19 sequelae also can lead to cardiomyopathy and heart failure. Now let me just show you a simplistic diagram that I put together more than 30 years ago, how hypertension leads to heart failure. On the one hand, causes pressure-induced left ventricular hypertrophy. On the other hand, as I mentioned earlier, most patients with hypertension will have multiple risk factors that increases the risk of acute MI, and these together can lead to the process of LV remodeling, subsequently leading to LV dilatation and dysfunction and congestive heart failure and subsequent related sequelae. Now let me show you a very interesting diagram which should impress you. In patients with diabetes and hypertension, treatment of blood pressure a little bit more intensively as compared to the routine. In the UK PDS trial, just 10 millimeter better reduction of blood pressure, systolic blood pressure, 154 in the control, 144 in the intervention arm, led to halving the risk of heart failure. The risk of heart failure, as you can see, was reduced by 56%, and so were other complications related to diabetes and hypertension. Now, we must also remember, as I mentioned to you, that heart failure is a disease of the elderly people, and quite often the elderly people have hypertension. So this is a trial of people above the age of 80 years. I want to emphasize that as Indian population is aging, more and more elderly people will be seen, and right now they are quite frequently ignored. They are not well taken care of. But in these elderly people, you can see the treatment, active treatment of high blood pressure was associated with more than 60% reduction in the death due to heart failure, which is very, very important to keep in mind. And we should not ignore treating elderly people's hypertension just because of their age, because it will prevent the subsequent development of fatal, non-fatal stroke and heart failure. Now let me come back to the pathophysiology of heart failure. This is a diagram from a lecture Gene Brownwell gave more than 30 years ago, the Shattuck lecture in 2000. What he emphasized was what I mentioned in the earlier slide. With myocardial injury, there is perturbations of cardiac function. This leads to some acutely adaptive changes, which is the activation of neurohormonal axis, adrenergic nervous system, renin-angiotensin-aldosterone system, endothelin, and many others. Acutely, they are adaptive, they maintain circulation, and as such, they are called adaptive. However, if not properly treated and are not interrupted, they become maladaptive, and this maladaptive neurohormonal system is what causes the hypertrophy, remodeling, apoptosis, and subsequent vicious cycle of cardiac dysfunction. And our focus in the last 30 years has been to inhibit this maladaptive phenomenon, which is essentially blocking the neurohormonal activation, that is by ACE inhibitor, aldosterone inhibitors, beta blockers, etc. So this is a diagram I developed some years ago, emphasizing the various stages of heart failure that we described in the previous guidelines. Stage A, B, C, D. Let me just spend a moment. Stage A is when there is cardiovascular disease present, but there is no LV dysfunction. This is in the setting of hypertension, coronary artery disease, and this leads to LV hypertrophy and a subsequent myocardial infarction, which then can lead to stage B, which is LV remodeling dysfunction. This is when left ventricular is dysfunctional, and it is at this stage we should be interrupting this process by neurohormonal blockade for preventing further remodeling, and this is done very effectively by renin-angiotensin-aldosterone blockade and sympathetic adrenergic system blockade by beta blockers. If we don't interrupt here, we will then have overt heart failure and then subsequently terminal stage of heart failure, which then perpetuates the whole problem. So this is very important. First of all, most important thing one can do is prevent heart failure altogether. And if you don't prevent it, treat it properly subsequently. So let us talk about what are the goals of therapy in patients with heart failure. Of course, first and foremost goal in any patient is to relieve the symptoms. This can be done by simple measures such as salt restriction, diuretics, and most newer drugs like SGLT2 inhibitor. The other goal should be slowing the disease progression. This can be done by neurohormonal blockade with ACE inhibitors, beta blockers, and also to some extent resynchronization therapy. Of course, as I mentioned, heart failure is associated with significant increased mortality, and this can be reduced by a number of therapies that are listed here. I will review with them very briefly, but we must keep in mind that one of the bases of reducing mortality is blocking the renin-angiotensin-aldosterone system, beta blockade, and also more recently device therapy and isosorbide dinitrate. So I keep mentioning the activation of renin-angiotensin system and sympathetic adrenergic system because this is the system that is really involved in LV remodeling. You can see the activation of this system which is due to the poor cardiac performance, leads to all of the cellular and structural changes such as LV remodeling, progressive LV dysfunction, and subsequent manifestation of symptoms and consequences of heart failure. And there are a variety of different processes that are involved, including fibrosis, apoptosis, hypertrophy, molecular alterations, and myotoxicity. And this leads to a variety of different changes, such as increase in preload, increase in afterload, sodium and water retention, and subsequently leading to all the symptoms of heart failure that you're so well familiar with. So I think clearly the main axis of therapy is RAS inhibitor, and we saw the benefit of in the SOLT trial. There was a 23% risk reduction compared to those who were not on RAS inhibitor and were only on DGen diuretic. Subsequent, the beta blocker trial showed further 34% reduction on top of the RAS inhibition, and clearly we showed that in some patients, addition of ARB on top of other therapies was also beneficial. Now, let me briefly mention about the pivotal role of aldosterone. Although we block some of it by ACE inhibitor therapy, we must keep in mind that there is an aldosterone escape. This increased amount of aldosterone causes collagen deposition, fibrosis, and further worsening of LV remodeling. And it also at the same time causes salt and water retention, leading to edema and deprivation of potassium, leading to arrhythmias and subsequent increased risk of sudden cardiac death. We showed many years ago, more than 20 years ago now, that aldosterone antagonist therapy can not only reduce edema and other water retention, it also prevents the myocardial fibrosis and prevents sudden cardiac death. And this has been shown now that we can also treat patients early on with post-myocardial infarction. This is the emphasis trial that showed that patients post-myocardial infarction that were treated with eplerenone had about 37% reduction in the risk of heart failure or death from cardiovascular cause, and death from any cause was also favorably affected. Now, of course, we can treat these patients with the available drugs, angiotensin receptor blocker, ACE inhibitor, beta blocker, but still you can see that despite reductions, still 60% of the patients remain at risk of subsequent problems. And this is where the paradigm trial that was done with ARNI, neprilysin inhibition with ACE inhibition compared with ACE inhibitor was shown to be highly effective. Time does not permit for me to talk about the escape phenomenon, but in patients who are treated with ACE inhibitor, ARB and beta blocker, still there is much residual risk remaining. And clearly in this slide, you can see that neprilysin inhibition with valsartan, with Entresto, was associated with 20% reduction in the risk of hospitalization or death, which was highly, highly significant. It was shown that not only the death from any CV causes was reduced, but hospitalization was reduced equally by 21%. Now, the next drug that comes in mind and that has only been known to us in the last 5 years is the drugs called SGLT2 inhibitor. SGLT2 inhibitors were primarily investigated for treatment of diabetes, but we were surprised to find in the EMPEROR outcome trial that blocking the reabsorption of glucose by SGLT2 inhibitors, 90% is blocked. This was associated with significant benefit in preventing heart failure onset and subsequent hospitalization. Now, we must keep in mind that SGLT2 inhibitors not only block the reabsorption of SGLT2, not only block the reabsorption of glucose, but they also create the natriuresis, that is sodium excretion. So not only there is significant glycosuria, but there is also natriuresis. So I call SGLT2 inhibitors an optimal diuretic, if you will, that causes significant volume loss and decrease in weight and also energy loss. And there are multiple drugs that are available in this class. The first 3 drugs are EMPA, DAPA, and canagliflozin. They were investigated for diabetes, but I think they have a pivotal role in heart failure now. And this slide summarizes some of these trials. You can see here the results from the first trial, EMPEROR outcome trial, showing a significant 25% reduction in combined endpoint. Here is the DAPA-HF trial. It shows again about 20 some odd percent reduction, 26% reduction here also in the combined endpoint of CV death, heart failure hospitalization, or visit to urgent care for heart failure. And this is a slide from the most recent trial that we have done with sotagliflozin, which is a SGLT1 and SGLT2 combined inhibitor. And this also shows a dramatic reduction in this patient with acute heart failure. And clearly, this is of high benefit. Now, what is surprising in the DAPA HF trial is that regardless of whether the patient had diabetes or not, there was benefit regardless of the presence of diabetes. So I think the benefit of SGLT2 inhibitors is not related to the presence of hyperglycemia or diabetes. It is direct effect on diuresis as well as probably on myocardial metabolism. So based on these trials and a very quick summary of what I provided to you, at the present time, we consider these as the four pillars of medical therapy for heart failure with reduced ejection fraction. As I mentioned, ACE inhibitor, ARB, and when needed, ARNI. That's the first line therapy for most patients. Beta blocker should be utilized in most patients, and mineralocorticoid receptor antagonists, and including the most recent data with finerenone, could be highly beneficial. And SGLT2 inhibitors now should be utilized in patients with both systolic as well as diastolic heart failure. And this is agreed upon in the European Society of Cardiology guidelines as well. Now, what is very important for the clinicians to keep in mind is that the benefits of this quadruple therapy is evident within 30 days of initiation. So think of heart failure as worse than many cancers. Which chemotherapy provides the benefit within 30 days to the patient? None that I'm aware of. On the contrary, these therapies for heart failure show reductions with anywhere between 25%, and if you use all of them, 58% reduction within 1 month of therapy. So clearly, if you're not treating your patient with all of that, you are really missing the boat. And this is very, very nicely emphasized that when you look at the patient with heart failure and look at their mortality as one with placebo on, and then add drugs such as ACE inhibitor, beta blockers, and have all four drugs of therapy, you can see that you can reduce their mortality by 61%, and so that there is now a hazard ratio of only 30.39. So very, very important to keep in mind. And this benefit is seen continuously throughout the follow-up period. And this provides a prolongation of life in heart failure patient by 6 years, which is phenomenal compared to any other disease such as cancer. So I think the last 2 or 3 slides I want to show you is that the patients with elderly patients, a patient with hypertension, they are now presenting to us with preserved ejection fraction heart failure, so-called in popular term as diastolic heart failure, because their LV systolic function is preserved, but they have significant difficulty in terms of their breathing, they retain fluid and other things. However, although time doesn't permit for me to discuss in detail, you must determine what is the phenotypic type of the patient with HFpEF, the so-called diastolic heart failure. Is it due to hypertension? Is it due to amyloid infiltration? Is it due to renal disease? Is it due to coronary artery disease? Is it due to metabolic syndrome or pulmonary hypertension? Because each subcategory will have a different kind of therapeutic approach. So I want to finish now by emphasizing the treatment of patients with preserved ejection fraction or so-called diastolic heart failure is primarily focused in the past on relieving symptoms and reducing congestion and preventing hospitalization. But now we have a class of drug that is highly effective in preventing rehospitalization as well as their subsequent mortality, and these are SGLT2 inhibitors. 2 drugs have been shown, DAPA and empagliflozin have been shown to provide such significant benefit. This is the trial Emperor Preserve that I was a PI for. In 6,000 patients, LV ejection fraction more than 40%. The primary outcome was composite of CV death or heart failure hospitalization, and significant benefit was seen. The other trial was delivered. This was with dapagliflozin against more than 6,000 patients, LVEF 40% or more, and this also shows substantial benefit. So at the present time, when we talk about management of patients with heart failure with ejection fraction, of course, we give diuretics for fluid retention, but the main therapy should be with SGLT2 inhibitors. Two drugs have directly shown evidence of benefit. These are dapagliflozin and empagliflozin, and certainly we should treat the underlying problems such as hypertension, infiltrative cardiomyopathy, etc. So I don't have time to go into the devices and cell transplantation. So I'd like to conclude by showing the state-of-art therapy for heart failure in 2025 and beyond. We should be looking at the various treatments that are available and should really be defining the heart failure patient as patients who are at very high risk of death and morbidity due to recurrent hospitalization and compromised quality of life. And clearly, in patients who have heart failure with reduced ejection fraction, we should not be focusing just on diuretic, which many clinicians do. Diuretics only provide relief from congestive state and have no survival benefit, and they are a short-term patching phenomenon. In ACE intolerant patient, ARBs can be utilized, but ACE inhibitors or ARNI should be the basis therapy. The sacubitril valsartan, ARNI, or in various countries, different name, but we call it Entresto here, and very highly effective. And clearly, we must not forget the pivotal role of aldosterone antagonists as well as SGLT2 inhibitors. And in patients with heart failure with ejection fraction, in addition to the symptomatic relief, we should be treating all of them with SGLT2 inhibitors. Now, I want to end on a preventive note. That is the best strategy for heart failure is prevention by timely treatment of risk factor, particularly simple conditions such as hypertension and or better control of cardiometabolic dysfunction such as diabetes, CKD, and metabolic syndrome. So my suggestions for improving care of patients with heart failure in India is we need to develop and adopt uniform diagnostic criteria. We need to implement reliable surveillance programs such as heart failure registries, which I have tried on multiple occasions but have failed. Really, there are no very good registries that I'm aware of. We should also establish standardized protocol for both inpatient and outpatient care of heart failure patients and post-discharge follow-up, which is extremely crucial in our experience. Develop and adopt national practice guidelines for heart failure and implement primary and secondary prevention guidelines to treat simple diseases such as hypertension, diabetes, coronary artery disease, and treat patients with appropriate drug therapy. Future direction has many different venues, but I think time doesn't permit for me to get into it. So thank you very much for your attention.
Thank you, Dr. Prakash Deedwania, for a very comprehensive talk, and I would like you to stay back because we'll have some discussion after that. But Dr. M.K. Das is having a huge interest, and he has been speaking about heart failure all over the globe, including ASC and including ACC, and he is a past president of Cardiological Society of India. He is from Kolkata, having a huge academic interest and potential, and he has also organized Cardiological Society of India meetings earlier. He will be talking about basically the medicines, the role, especially the guideline-directed medical therapy in heart failure. Let me introduce our panelist and chairperson. I can see on Zoom Dr. Abdul Rashid Khan. He's our old friend, and he invited a couple of times to Karachi in Pakistan, and he's also one of the very senior and eminent cardiologists from Karachi. And he's sitting there. He wanted to come, but we couldn't go because of the visa issues. And but still, we have on Zoom him, Dr. Abdul Rashid Khan. And then sitting here on the chair is Dr. Vanda Bagga. She is the Director Health Services, Government of Delhi, and she's having a more than, I think, 5,000 doctors or 3,000 doctors working under her capacity in Delhi. And they'll all be part of this program, and few are on the Zoom, Facebook, and other things. So let me start with Dr. M.K. Das to start this protocol, and then we'll have a small few minutes of panel discussion after on the heart failure. And Dr. Mukesh Goel will be talking about the surgical part. Thank you, Dr. Das, to be there and waiting for some time, small delay, and I think you'll pardon me for that.
Thank you, Dr. Gupta, for arranging this conference online, and also to the organizers for giving me the opportunity to talk on this issue, that is the guideline directed medical therapy for heart failure. There are fantastic presentations from Dr. Deedwania on several occasions, and this one is one of them. And he has really put his points across the table that these are the methods by which you can follow the therapy for heart failure. But the issues of implementation is always haunting us, and that is the problem with the heart failure management. It has evolved significantly over a period of years. Various strategies have been formulated, and professional organizations have really worked hard for giving this kind of guidelines. They have definitely yielded results by not only reducing the recurrent hospitalization, which is an important marker of overall prognosis of heart failure, and it has also reduced the mortality, especially with the advent of novel therapeutic and devices. But that is not the total story with the GDMT and heart failure. The global burden is always very high, and we in this subcontinent, South Asia, actually we have got the heart failure incidence 10 years earlier than the Western counterparts. And that is why we'll have to give more emphasis on the guidelines. But the problem is definitely not only with the various implementation techniques, but also there is some definitional problem with the heart failure. We are more focusing on the ejection fraction, and we are classifying it and also giving the therapeutic agents according to the heart, what is called the ejection fraction over a period of time. And you can see the list of drugs that have really improved the ejection fraction over a period of time. And as Dr. Deedwania has highlighted, that the list is going to be more and more. And the latest one is finerenone, tirzepatide, semaglutide, which are coming in a very big way in not only heart failure alone, but also heart failure with chronic renal disease and also some metabolic problems. And the whole paradigm shifted with the ARNI, as Dr. Deedwania has told us, and there is 38% reduction in mortality. And you can see here that in all kinds of heart failure, definitely there is reduction in not only the heart failure hospitalization, but also the mortality, overall mortality, as well as the non-cardiovascular mortality. SGLT2 inhibitors, they have changed the scenario, and also be more effective in heart failure with preserved ejection fraction or more ejection fraction rather than the EMPA and other SGLT2 inhibitors. And that's how we have come to the conclusion that the dapagliflozin is delivering an equitable care for patients with heart failure. There are different drugs, as I've been told, and I have already told that the more the ejection fraction is high, the SGLT2 inhibitors are more beneficial, and the other drugs are more beneficial with the less ejection fraction, less than 50%. And definitely with the declining benefit of ARNI, ARB, and BB with the higher ejection fraction. This is one of the factors which is inhibiting our implementation. That is the chronic renal disease, and they are possibly some of the other drugs which are non-interfering with the renal failure or the EGFR, like ivabradine and vericiguat. They can be quite handy. Another factor that is influencing the result of the guideline-directed medical therapy with the four foundational therapy is the presence of iron deficiency anemia. And this iron deficiency anemia is not exactly like the other kinds of iron deficiency anemia. Here, with the heart failure, something else is happening. That's why ferric maltose is giving better result with the injection form. And these are the treatments for this thing. And the ultimately we possibly thought that we got the GDMT and we are giving the four foundational therapies, and the add-on therapies like hydrogen nitrates, ICD-CRTD, ivabradine, digoxin, vericiguat could be given after the optimization of the guideline-directed medical therapy. And if they fail also, then we can think about the LV, AD, or heart transplantation. Of course, in acute episodes, we have to take care of them with the inotropes and the other drugs. And here I would like to mention about the omecamtiv mecarbil also, which also helps in the heart failure with the reduced ejection fraction. Now, so far the device therapy is concerned, we have seen recently that the CRTD's implantation, especially in the elderly patients, has come down after after following the GDMT. So these are some of the evidences. So far, so good. But what is very surprising and very important to be known to all of us, that published prescription rate for heart failure reduced ejection fraction, and studies are showing that though beta blockers are being used, but these are not being used in old patients, and also same thing is happening with the ACE or RNE or MRA and ivabradine, even after being informed as the guideline-directed medical therapy is not being implemented. And that is not only applicable to India or Pakistan or Bangladesh or South Asian countries or other countries in Asia. It is well applicable to even the advanced countries. And these are some of the data which are showing that the implementation of the drugs are not being followed in most of the countries in India, and that is well applicable to the advanced countries like Japan, Sweden, and United States. You can see the various statistics over there. I'm not going into the detail of it. And what has been found as a sort of conclusion, I would like to say that patients without GDMT cohort had 29% increased risk of mortality. Patients with the GDMT, definitely there will be much more beneficial effect. Now, what went wrong exactly? There were three fronts where we went wrong. One was the patient-related, second was the treatment-related, and third was therapeutic inertia or doctors-related. These are patient-related factors: increasing age, depression, frailty, food security, home security, communication, social isolation, transports. All these were responsible for not implementing the GDMT. There were also related issues with the treatment, like the intolerance to some of the drugs or hypotension caused by some of the drugs like RSS inhibitors, etc. And there were also the therapeutic inertia. And even though we are highlighting GDMT in various lectures and communications, but they are not being followed by the physicians, and that should be taken care of. So what should we do? There are various methods, like we can take the help of traditional sequencing, sequential, early dose escalation, rapid sequencing, simultaneous initiation, prioritizing enabling therapies, sequencing trials, and polypill. Polypill is another good sort of methodology or method by which we can reduce the lack of implementation, and we can give the confidence to the patients that with a single drug or just one or two drugs we can give the equal benefits. Now, for achieving this, but there are so many other quality control improvement methods. But out of this, possibly electronically recorded therapeutic measures is very, very important, and that can be possible by using the digital technology with the different methods like remote monitoring, then EHR enabled identification and all. And I'm not going into the detail of it, but telemedicine is coming in a very big way, and it still requires validation for total implementation, but this will help in the long run. EHR based, I have already said that prompt heart failure has shown some demonstrable improvement in the primary outcome of an increase in the number of GDMT classes prescribed at 30 days and GDMT dose with targeted integrated integrated approach, and they can be prompted by the electronic recording. Now, this is a very important message, phenotyping beyond ejection fraction, because ejection fraction may not explain everything, and that's why we can pick up certain cohorts based on the phenotyping and phenomapping, and these cohorts can give some specific groups who can be treated with the specific kinds of drugs. Thereby, you can reduce the pill burden, and we can get the benefits of the patients. These are some of the additional methods which Dr. Deedwania actually skipped, but these are coming in the futuristic way, like Biventrix, which remodel the dilated heart, then Barostim Neo, which can which are not the patients which are not candidates for CRT, etc. Then they can be implemented. HeartMate and cardiac contractility modulation device is also coming in a very big way. Artificial intelligence can give rise to new phenotype by continuous feedback mechanism, and that's how we can improve the GDMT and thereby improve the ultimately mortality and morbidity. So to give you the carry home message, individualizing strategies for attenuating the burden of comorbidities and heart failure related rehospitalization is the cornerstone in achieving the therapeutic goal for heart failure, which is reducing the mortality and also morbidity. The predictors for heart failure rehospitalization to be evaluated and taken care of in an appropriate time: therapeutic inertia, lack of adherence to the GDMT, patient's inertia, and barriers for implementing the GDMT should be taken care of. A coherent statistical model for constructing risk assessment should be attempted, and focus for our own population, Asian heart failure registry, over a prolonged period of time should be taken up, and technological advancement like remote monitoring systems, machine learning, and artificial intelligence and application of therapeutic digital tools may prove to be the future of the holistic heart failure management. Thank you very much.
I think a very important, comprehensive, educative talk by Dr. M.K. Das, who is also the president of the Asian Heart Federation. So we are very proud of him. And now, before we go into panel discussion, Dr. Abdul Rashid Khan is there. We'll have a very quick 5 minutes or 7 minutes talk by our surgical colleague, Dr. Mukesh Goel. He will just touch upon the surgical part of the heart failure, surgical treatment. Let's see what he's going to talk about. And then Dr. Prakash Deedwania, I know it's very late, more than midnight. So yeah, so I would request you if you can just, stay back. Dr. Mukesh Goel, please go ahead with your talk. Then we'll have a small panel discussion. Can you come just here? Your slides are there. Can we have the slides of Dr. Mukesh Goel? Dr. Mukesh Goel is a senior consultant surgeon in our hospital in Apollo, and his work areas bypass surgery, mitral valve replacement, repair, heart transplant, lung transplant. So we are also doing heart and lung transplant, LVAD, ECMO services, MICS, minimal invasive cardiac surgery, and aortic surgery. So let's go ahead with his talk. We are already running late. I request him to give the major salient points about his talk, and then we'll have a small 5 minutes panel discussion with our colleagues.
Good morning, everyone. Thank you, Dr. Vivek, for giving this opportunity to present my thoughts and my work in front of you. So, Dr. Das, he has just touched upon what should be the optimal medical management and how it improves survival and quality of life in patients who are suffering from end-stage heart failure. So heart failure, as we know that it is just inability of the heart to supply the need of the body. I'll just skip because we have go through much of the medical management and heart failure. So despite the optical management and very encouraging results of various agents for improving heart failure results, there is still a 50% mortality at end of 5 years in patients who are suffering with end-stage heart failure. So what is there beyond these drugs? How we can help these patients? So the further advanced treatment for patients who are now no more doing okay with medical management is left ventricular assist device, or commonly called LVAD, and heart transplant. So when you should, as a physician, refer to your patient to a heart failure specialist. So as you know that with the medical management in consultation with the cardiologist and heart failure specialist, you can manage your patients, you can adjust their dosage. But when the symptoms are not improving or getting worse, despite your maximal tolerated medical dosage, and ejection fraction is less than 35%, and either because of the treatment or because of the worsening heart failure, the other organ functions is deteriorating, like renal function or hepatic function. So these patients should be referred for advanced treatment. So when a patient will require a definite transplant or a LVAD is when the patient is NYHA 3 or 4 despite guideline directed medical therapy. He is intolerant or refractory to the agents of medical therapy like ACE inhibitors, ARBs, beta blockers, or ARNI because of the blood pressure or heart rate issues or symptomatic issues. That if you try to increase the dose, the patient becomes too much more symptomatic rather than improving. And the daily diuretic dose is more than 1.5 milligram per kg per day. So diuretic, mind you, is not a part of guideline directed medical therapy. The diuretics, they do not improve survival, or they are only symptomatic treatment in patients who are suffering with symptoms of congestion. So when the diuretic dose exceeds 1.5 milligram per kg per day, that is a basically red sign, then the patient is developing renal or hepatic dysfunction. The patient has got a congestive heart failure related hospital admission within last 6 months. So these patients should be considered for transplant or LVAD, whatever be the indication. So mind you, despite being the modern LVADs and everything available, transplant is still the gold standard. But however, every patient cannot undergo a transplant because there are a whole lot of contraindication to transplant. And how do we match donor with recipients? First of all, we match ABO blood group. Like blood transfusion, we match the donor A with A, B with B, and AB with AB. However, like blood transfusion, O is a universal donor and AB is a universal recipient. Then the body weight between the donor and the recipient should be within 20%. This is just a few pictures of a transplant, how it is conducted. This is a heart which is being now retrieved from the donor's body. Sometime we have to transport heart with a charter flight because the ischemic time which is available for transporting a heart is very less. So this is, we transported from Mumbai to Delhi. So we had to hire a charter for this. And it's a like great logistic and arrangement we have to make. And on the right side, you can see that this is a coordinator who is on phone. He's already requesting for a green corridor at Delhi airport to Apollo Hospital. And along with him is the anesthetist. He's telling the recipient team in Apollo OT that we are now entered into the aircraft and you can start the recipient operation. So this is a heart which is being taken out from the recipient, the diseased and dilated. You can see the size of the heart, too much diseased and dilated. It is lying outside the excised heart from the recipient. It's a donor heart being lowered into the body. And this is how we connect the donor heart to the recipient body. And this is on the left, you can see that how it looks like once the heart has been taken out. On the posterior most is the cuff of the left atrium. Then stump of superior vena cava, inferior vena cava, aorta and pulmonary artery. And these are 5 anastomoses through which we connect to the donor heart to the recipient body. This is a picture of a 5-year-old boy we transplanted 4 years back. He still date the youngest transplant recipient in Asia. He was 5 months old. Still this landmark holds true. And this is his the same boy on follow-up. Now he's 3-year-old and thriving well. The first transplant we did at Apollo Hospital, the patient was sent home after 10 days. This is another 2-year-old baby. I will come to it later also when I will be discussing LVADs and biventricular assist devices or total artificial heart. So she was on, for 4 months, she was on Berlin heart or a biventricular assist device, and then we transplanted her. And this is, she's going home, and her mother on the right side sent a picture playing for 3 months back. The another 2 patients we going home after transplant, recent one. The post-operative management after heart transplant is standard like liver or kidney transplant. There is no difference. These are on lifelong immunosuppressant, tacrolimus, mycophenolate, and prednisolone for few months. Surveillance biopsy is done in the first year to know if there is any rejection happening or not, so that we can adjust the dosage. Nowadays, we can do sometime endomyocardial biopsy, and sometime we can do a blood test, simple blood test, which can tell us about the status of the rejection, and that is called cell-free donor-derived DNA. But there are limitations to heart transplant, like you know that heart can only be retrieved from a suitable brain-dead donor whose family has agreed for the donation. And then there are logistic issues sometime. Last week what happened that there was a donor at Jodhpur, and the family wanted retrieval to be done and the body to be handed over by 6 a.m. And we got a call at 12 a.m. in the night, and that this donor is available. So though we had the recipient, but there are no nighttime landing facility available at Jodhpur airport. So that heart and lung both got wasted because of the logistic issue. So this is one logistic nightmare especially in Indian setting. And advanced age patients are obviously not suitable for heart transplant, high pulmonary vascular resistance, other comorbidities like that. So what are the options for these patients who are not fit for heart transplant is LV assist devices. So the rationale behind using LV assist devices, this was published in New England Journal of Medicine in 2001, where the difference of a patient on LVAD versus on medical management. So there is a huge difference in the survival at 2 years of follow-up. So this established LVAD as a legitimate therapy for patients who are not for heart transplant, but who are compared to medical therapy. So these devices, they have improved and changed over the years. This was on the left is the first LVAD which was available. It had to be kept outside of the body with the cannula connection going through the body. Then in the middle, it was a HeartMate 2 device, where it was totally implantable with only a cable coming out of the skin for connecting to the drive line. And it has further improved on the right. It is a HeartMate 3, which is the latest device available. So this is how LVAD looks, that it is a device which is connected to the left ventricle inside the pericardial cavity. Then there is a which is drawing blood from the left ventricle. Then there is a graft which is connected to the left ventricle to the aorta, so that this device, it draws blood from the left ventricle and pumps it into the aorta. So it is it has taken over the work of the left ventricle. It can give up to 8 to 10 liters of flow per minute as per the requirement of the patient. And so there is a drive line which comes from the patient's skin near in the abdomen, which is connected to the console, and there are 2 battery packs. So purpose of LVAD therapy is bridge to transplant. That is, the patient who are otherwise fit for transplant and they are waiting for transplant, but they are too sick, because it might take 3 months, 6 months, or even a year or 2 years for a suitable heart to become available. And when we think that this patient is not too sick to survive for that period, so we can put those patients on LVAD and then later on transplant them. This is called bridge to transplant. And then destination therapy, when we know that the patients are not suitable for transplant, and LVADs are given as a definitive lifelong therapy. But because this LVAD, they only help the left ventricle, so the patient has to have a good right heart function for this to work properly, and the patient should not be too frail. So that's why any patient we decide to put an LVAD, we very diligently we study the right heart parameters, so that the right heart can take the load of the left ventricle. Because the right heart becomes the functioning ventricle. The left ventricle becomes a simple conduit for blood to the left ventricular device. Then timing of LVAD is very important, that the patient should not be too sick. It is like buying a banana. If you buy a banana like at number 6, when the bananas are totally ripe, so you will hardly be able to eat at home, because next day they will be rotten. So you will like that banana which are at the stage of 4, so that in next 3-4 days you can consume one by one easily. So that's why these LVAD patients should be referred well in time, before they become they have irreversible liver or kidney function or some infection or any other problem. So the LVADs, more than 30,000 LVADs have been implanted worldwide in last 10 years, and there is good long-term survival with LVAD. And a 3-year survival on LVAD is now approaching that of a heart transplant, near 80%. Versus medical therapy, the comparable patients on LVAD and medical therapy, there is a difference at 2 years, 3-year survival. 2-year survival is 28% versus 80% with HeartMate 3. So you can see the difference, a huge difference. 79% patients on LVAD and 49% on the comparable stage of the patient NYHA class who were on medical therapy. The post-operative complication rate is very less, hardly 1% pump thrombosis rate per annum. So this is a patient we transplanted with, we implanted a LVAD last year. It's almost completing 1 year. After 1 month, he is going back to his country. This is how the post-operative X-ray looks like. So this is the device which is connected to the left ventricle, and you can see a cannula which is going towards the LV and looking towards the mitral valve. This another patient, he was on LVAD for 3 years, and the same patient I showed you a picture earlier after the heart transplant. So after 3 years, he got a heart and we transplanted him. So this is how transplant, this LVAD looks like. So the LVAD is totally inside the body, chest cavity, and there is a small drive line which comes out of the body, and this is like under dressing, and this is a small battery pack he has to carry. The patient can take shower, anything, do exercise, do running, jogging, everything. These LVADs are so good. So I will come to what are the options in small children where these LVADs cannot be implanted. So this was a 2-year-old girl who came to us very sick in chronic congestive heart failure with cardiogenic shock. And she did not improve despite 1 month of ventilation and inotrope, and she developed secondary renal and hepatic dysfunction. So we implanted her with this Berlin heart. So you can see these 4 big cannulas which are going inside the body because it's a small 2-year-old girl. And I'll show you the. So this is the right heart pump and this is the left heart pump. And right heart is taking blood out from the right atrium and giving to the pulmonary artery. And the left heart pump is taking blood from the left ventricle and giving it to the aorta. So this is a basically biventricular assist device or total artificial heart. The only kind of a case in India till date, and we kept this patient for 4 months on this biventricular assist device, and then we transplanted her. So while on the BIVAD, she was being taken out of the ICU for a stroll and fresh air. And this is on the right after transplant. So I will skip on temporary VATs in interest of time. And soon we are there is a work going on with the wireless charging of LVAT. So there will not be any drive line which is coming out of the skin. And there will be a fully implantable VAT which will totally be inside the heart and nothing in the pericardial cavity. But the challenges with the LVAD therapies are awareness and acceptance and cost. Because this HeartMate 3, it costs something around like 1 crore in total, the device cost and the surgical management cost. And every heart failure hospitalization increases the patient risk of death. So with every hospitalization, the survival will come down. So we should not think that we have medically managed this patient and they will be all right. They just suddenly die at home. So heart failure requires a multidisciplinary approach depending on the patient's symptom and survival. And I will appeal for organ donation, that spread the awareness about organ donation. It's one organ donor saves 8 lives. Thank you very much for your kind attention.
Thank you, Dr. Goel, Mukesh, very nice presentation. Doctor, may I introduce Dr. Mansoor Ahmad, who has also joined. Can we see that Zoom here? He's also from Pakistan and Karachi, and very eminent figure, and he has been in academic institute, and he's also a part of the panel now. So, Dr. Prakash Deedwania, I know that I'm doing a little injustice to you. We have a friend, Dr. Vivek Kumar, who will talk about the valves and heart failure. Very quickly, 5 minutes, because he has to go, otherwise we could have kept him in the next session. So Vivek, please come and otherwise he was supposed to speak on complete valve interventions, but I have requested him in the interest of the actually American people who have to sleep because they're already 1 a.m. there, where he's sitting. So I just want him, and then we want actually 2 minutes of some discussion on the heart failure subject. So, okay, please, Vivek, please go ahead with the presentation, very brief, whatever you want to speak on this issue. He's our colleague in Apollo Hospital and senior cardiologist and doing a lot of work other than angioplasties. He's also doing, we all together doing some TAVI and also structural heart and pacemakers and all.
Very good morning to everybody. Thank you so much, Dr. Vivek Gupta, sir, and he's been very kind enough to adjust me in this slot. And without wasting any time, let me proceed to my talk, which is on heart valves and treatment that we could expect in 2025. Can you play my slides, please? It's Vivek Gupta. Can you? So definitely, we have already gone through thoughts on medical management and the most advanced, that is replacing the heart or replacing it with an artificial heart in form of LVAD. This is my talk. Thank you. Okay. So we are now at the end of 2024. For heart valves and heart interventions, it has been a great year, no doubt. We have done some great work, new things are happening, and what we can look forward in 2025. And obviously, it's going to start from where we had begun. So what we are going to see in near future is that we are seeing aging India, where people will be older and people will be having comorbidities in form of multiple valvular disease, CAD, CKD, liver failure, CVA, and cancers. And these patients will require advanced cardiac care, and a very challenging aspects would be there because a lot of these patients would not be a good candidate for open heart surgery. So obviously, we have to think out of box and think about new innovations and making it practical in our daily practice. So these are the valves that we are concerned of. So we know that we have 4 valves in the heart: aortic valve, mitral valve, tricuspid valve, and pulmonary valve. And till about 5-10 years back, I'll say 15-20 years back, the only option for these patients have been going for a open heart surgery, undergoing a valve repair or a mitral replacement. But as I said, that with aging population, challenges are there. A lot of these patients may not be good candidates for valve surgery in form of open heart surgery. So these are the unmet needs in cardiac interventions. And to large extent today, at the end of 2024, we can say that we have really accomplished a lot of interventions and possibilities have been made that these patients could be treated. Like for example, this patient, 68-year-old male having severe symptoms of aortic stenosis and being very frail, he was not a good candidate for open heart surgery. So mic is not working, sorry. Yeah. Hello. So if we don't treat these patients, he is not going to survive more than 2 years. So surgery, if you ask him, the mortality in such patients could be as high as more than 10%. We say these patients to be very sick for going for open heart surgery. What we can do for such patients, we can offer them a TAVI, that is transcatheter valve implantation. But before that, a lot of we have literature there, evidence there that in normal patients also who are more than 65 years old, we can offer them a transcatheter valve intervention, whether the patient is risk for surgery or not. For younger patients less than 65 years, still surgical valve implantation, if the patient is not a high-risk patient for open heart surgery, is a good option. But for patients who are more than 65 years or above or having multiple risk factors, we can ideally offer them a valve intervention in form of a transcatheter valve intervention. And this is what we did in this patient. So you can see this is the calcified valve. We took a femoral artery access. We had a perclose device inside. We crossed the valve through this thermo wire, and then we proceeded to the valve implantation. And this was the evolute valve in this patient, and we could achieve a good result. And the patient was shifted to CCU for a day, and the next day the patient was fit enough to go home. And you can see the gradients improving. So one of the most common cause of heart failure symptoms is valve disease. And that's why if you treat these patients, the valve stenosis or regurgitation is treated, these patients improve very well. And similarly, we had another patient, a 67-year-old female patient, having calcified aorta, and such patients are not good for open heart surgery, and she underwent TAVI in form of with evolute valve, and you can see that the gradients are normal. So this is the patient, one of the earliest patient done, and within 24 hours, this patient could be good enough to go home. So we are now thinking about day-care TAVIs and things like happening. So definitely it could be a possibility in 2025 that we do an intervention in the morning and the patient is fit enough to go the next day. And it is very much possible. So not going to other cases, I'll just take you to some other aspects that apart from doing open heart surgery and in alternative to doing open heart surgery, going for valve intervention through a transcatheter valve intervention form, there could be possibilities. If you see in current scenario, as I said, that most of the patients who are elderly, we can offer them a TAVI, but younger patients and other issues like aortic regurgitation, still we have to lot of work going on. But sooner in aortic regurgitation, we are now having newer valves. So in such patients also, we can offer them a transcatheter valve implantation. This was another case. It was during my fellowship in Cleveland Clinic. So this patient had a previously implanted aortic valve, a bioprosthetic aortic valve that got degenerated, and TAVI was done in this patient. And this patient also required an angioplasty at the same setting. So it's not that if somebody is having a coronary artery disease and a valve disease, we cannot do valve intervention. We can do an angioplasty before or after the procedure, and as well as we can put a valve in these patients. So this was the case here, beautifully done and good result. So now coming to heart valves, which is most complex and is associated with a lot of heart failure patients, the mitral valve. So a lot of time these valves may be leaky, and we have data that if we change this valve, like for example in this patient, she had a previous mitral valve, biprosthetic valve implanted, and we did a transcatheter mitral valve replacement in this patient with a very beautiful result. And yes, we have to go transeptally through the interatrial septum into the left atrium. And this is how you implant we call this procedure a transcatheter mitral valve replacement. Now we have patient, this is the 3D echo before, and this is how the valve looked before, but if you see later on, the valve improved very well. Now we'll be having such patients. You can see this is a mitral valve, which is the PML is prolapsing, and the patient is having severe aortic mitral regurgitation. And this is a 94-year-old male. Can you offer this patient an open heart surgery? Not at all. And it will be very risky to offer such patients because they may be having multiple issues. But what we can offer these patients is going for what we call transcatheter end-to-end repair of leaflets. And this is what we call a mitral clip procedure. And here what we do is that we clip the mitral leaflets so that the regurgitant jet is treated, and a lot of heart failure patients, they die not because of the pump failure, they die because of the progressive MR happening and continuous overload that the LV is facing every day, and ultimately the patient developed end-stage heart failure and they die because of low output state. So in such patients, we have data that if we clip the mitral leaflets and correct the mitral regurgitation, we can treat this patient. And so this is how the clip looks in the fluoroscopy. And in this patient, 3 clips were used for repair of mitral regurgitation. Now, there are scenarios, we do BMV. So they are the most earliest structural heart intervention, and still mitral stenosis patient, if they are even high risk, we can try for a BMV to treat and reduce the gradient. And this is very much a very useful procedure. Now talking about tricuspid valves. So a lot of patients may be having a tricuspid regurgitation, and we may not be offering any surgical interventions for such patients because a lot of time they may be having liver dysfunction, low output state leading to cardiorenal syndrome. But in such patients also we can put what we call a trick valve. So this is a valve which is implanted. It's a bicavil valve. So we put 2 valves, one in the SVC-RA junction and another valve we put at the RA-IVC junction. So what it does is that it prevents the regurgitation of the tricuspid flow into the SVC and IVC, and over the time there is a positive remodeling in the RA-RV, and such patients improve symptomatically. So this was about tricuspid valve repair. So scenarios, future is very, very hopeful. There is a very much a possibility that most of the valves, including the pulmonary valve, whatever may the etiology or pathology going on, we can treat these patients with a transcatheter valvular interventions. But yes, one size doesn't fit all. We have to choose our patients. So the take-home message is that aging population brings in more and more patients with degenerative heart valve disease. Surgical techniques in form of MICS, robotic surgeries are evolving, but transcatheter valve intervention has become a boon. The transcatheter valve intervention is almost matching up to the unmet need of high-risk patients of valvular heart disease, but in future, maybe a routine valvular disease could be treated with a good result with a transcatheter procedure. But yes, carefully selecting the most appropriate patient for the most appropriate procedure is the key. Future evolutions are going on to tackle other complex scenarios. All I can say, future is bright, but today cost is a major limitation. This is myself at Cleveland Clinic. So I tell you briefly about the history of this building. This is a very historical building. The first angiography happened in this very building, and I had a privilege to be there. Thank you so much. Thank you so much to the organizers. Thank you, Dr. Vivek Gupta, sir, for this opportunity. Thank you so much.
Thank you, Vivek. Mine, same name. For a good talk, and you stay back on the panel. So we'll have a 5 minutes panel discussion. Very important. You see, sometimes people feel that panel discussion is not important. I personally feel that panel discussion, whatever you have been summarized, can be summarized to the. So may I invite Dr. Mansoor Ahmad from Pakistan to speak a few words about heart failure condition in Pakistan and how you are treating there, because sometimes we don't get major information from Pakistan. So it is good that you were all part of together before 1947. So I still feel that you are a younger brother, the country wise, but of course you are a senior colleague of mine from Karachi. So please introduce yourself quickly and then talk about this heart failure session a little yourself. Dr. Mansoor. You have to unmute yourself, yeah.
Okay, it's wonderful to see you again. I remember you being in Karachi with us for a while and myself meeting you in Delhi at one time. And it's wonderful to be here. Now, heart failure, as has been mentioned earlier, is probably going to be, is already a very big issue and is going to continue to grow as our populations grow. And I think we are living in very good time as compared to my training days when there was hardly any treatment known other than digitalis and diuretics. And today we have got wonderful drugs with prolonged life. And what I see and what I have learned from this talk today, that heart failure management.
Sorry, there is some change in the system. I want them to be on the. Are they online?
Not very high numbers, basically because of the cost issues, really, as has been mentioned already. But medication wise, I think it's good. Guideline directed medical treatment is now a norm here, and people are doing wonderfully well with this development, actually. And we look forward to newer development, as has been mentioned already. The cost will remain an issue in our part of the world, at least. Thank you.
Okay, thank you, Dr. Mansoor. A quick word from Dr. Abdul Rashid Khan, because we just wanted to know that whatever we are treating in India or Europe, are the same thing going on in Pakistan also, because the word is not knowing too much from your as a colleague. Just quickly summarize 3 minutes regarding the treatment protocol and how the patients are behaving and how the treatment is going on and the mortality rate otherwise. Dr. Abdul Rashid Khan. Yeah. Have you started speaking? I mean, you're not. Please unmute yourself.
Yeah. I think there may be some problem. There he is. Yeah.
Can you hear me now?
Yeah. Please go ahead. Yeah.
Thank you very much, Gupta, for inviting me to this one. Definitely, we are lacking in device therapy over here because of the cost. But as far as the GTMT is concerned, we are doing excellently over here as well. And the more patients are improving with this new therapy like RNI and this one. And I've seen in my personal heart failure. Definitely, the price is the main cause of the devices over here. If the prices is settled down or will bring to a lower end, definitely the devices will be implanting more and more in Pakistan too.
Okay, thank
As
you.
far as what you're doing over there, we have seen excellently well doing these things over there. I think if device price maybe not too much over there, but over here it's too costly.
That means devices also commonly being used other than, of course, the guideline directed medical therapy, including ARNI and SGLT. Okay, Dr. Ashokan has joined from Calicut. I don't know whether he listened to the talk given by Dr. M.K. Das and Dr. Prakash Deedwania. A very quick comment about, he's our dear friend, is a part of IECR since beginning, 2008. So, Ashokan, please go ahead with the 2 minutes of yours, just summarizing the heart failure.
So, good morning to you all. I think we had a very good, excellent session on heart failure, the most important topic, the most burning topic today. My question to Dr. Prakash Deedwania, I don't know whether it's available now, it's already late in the USA. So I think he's discussed everything. So my question is regarding the risk factors for the heart failure. He said the best thing is to treat risk factors. Now what we are facing is obesity, and obesity is the percentage of people become obese, and that's we all know that is one of the important risk factor for heart failure. So what about the newer drugs, GLP-1, agonist, semaglutide, and what is his opinion? So I don't think it's available now. It's already late in USA.
Okay. May I have a comment from Dr. Vanda Bagga, who is there, is a Director of Health Services in Delhi. She has been a panel since the beginning of the session. And after that, I will have Dr. M.K. Das last comment to close the session. Dr. Vanda Bagga, please go ahead with your whatever comments you want to say about the...
Thank you, Dr. Vivek, and a very good morning to all the esteemed faculty, international as well as national, and all the participants present here. In 2 minutes, I have to summarize. So, main key points that I take home are, one is the risk factors that Dr. Ashokan has just mentioned, identifying the risk factors, the accessibility, the preventive and promotive aspect, that is very important, and the protocols, SOPs, and the operational guidelines. So these are the factors that we need to address, and most of these we are addressing. So we are having national programs to address all these aspects in a very systematic, organized way. So one is the national program for non-communicable diseases, in which we know that more than 32% of the mortality is due to non-communicable diseases, and out of which 63% is because of the cardiovascular disease. And as per the sustainable goals, our goal is to reduce this premature mortality by 1/3 by the year 2030. So we are coming up with the national program for non-communicable disease, as well as the national program for healthcare of elderlies, that is going to address the issues of the elderly, how to catch them. But a very important aspect is the accessibility. So the healthcare reaches to the masses. Preventive aspect and promotive aspect has to be taken care of. That brings us to the very other extreme of the thing, in which we address not only the at-risk population from the elderly group, but also from other groups. So one is we have switched over from opportunistic outreach screening to the population-based screening, in which all the population above 30 years needs to be screened, and that is being done through the workers, including ASHA workers and ANM. So ASHA, as we know, is the initiative of India, that is accredited social health activists. So they do the line listing of all the population. They have the listing, and they have the listing of more than 30 years population, and they have been told how to do the screening. After the screening, again, if they know how to refer the patients. After the patient is referred, then what are the high risk groups? They have to follow a uniform protocol. So we have SOPs, including SOPs for hypertensive disorders of pregnancy, which has been a state initiative. Again, we go back from maternal health to catching them young by changing their healthcare behavior, so that there comes the adolescent health as well as our school health programs. So I can go on and on, but due to the lack of time, I don't think I can address more. But my most important request to all of these are that we wish to work in a team manner in which all the stakeholders need to have a proactive involvement. We need to upgrade our protocols, SOPs, procedures, operational guidelines as per the latest guidelines. We need to have access to the latest technological advancement, and the private partners are very much part of our team. All the guidelines, the SOPs that we formulate always have the experts from all the sectors. But now I would like to extend that to the international faculty, being a part of our government health programs as well. So thank you so much, Dr. Vivek.
Thank you, Dr. Vandna Bagga, for giving a really important comment and requirement, the need of the hour. Uh, I just wanted to thank Vivek and Mukesh for giving the LVAD and other issues of TAVI and other things. May I have the quick closing remark from Dr. M.K. Das? And before that, I would like to request Dr. Mansoor Ahmed and Dr. Abdul Rashid Khan to please, we'll have a coffee break after this, but we would like you to be part of the next session also, which will be on a live lecture from Dr. Rohan Jaisinghe from Australia, and then followed by the talk, on-site talk. So if Dr. Shokan and Dr. M. K. Das can also stay in that session, I'll be very much obliged. So Dr. M. K. Das, your closing comments on heart failure. Please unmute him. Yes. Okay.
Yeah, I think we had enough discussion, and definitely we are going in the right direction. And prevention is always better. A stitch in time saves nine, as is the usual proverb, and we should follow that. Having said all this, some of the risk factors are very, very important. Cardio, renal, metabolic, or CRM or CMR, whatever you call it, is a very, very big issue. Obesity is very big issue, and air pollution is another important issue, which is taking a toll on the not only coronary disease but also on heart failure. And from Cardiological Society of India, we are working on the primordial and primary prevention of the cardiac diseases in school children, and also we are training the children with the help of the teachers, so that we can take care of the stage A or stage B diseases right from the school level. And obesity, as Dr. Ashokon was asking, is very, very important issue. I would comment one point that in some of the patients of heart failure with the reduced ejection fraction, there can be an element of obstructive sleep apnea disorder. And we have found that after treating with the GDMT also, there may not be adequate improvement. In that case, CPAP helped, and that's how the risk factor management, including the complication management, as have been highlighted, are very, very important. And I think the discussions we can continue forever, but we must cut off a point. And thank you very much for joining the session. And all the panelists and speakers should be congratulated for their beautiful presentations.
Yeah, Doctor, we have to just give the memento, and your memento, I have to really courier to Kolkata and also to Pakistan. Just stay for a while. So we close this session now for the coffee break. And thank you, Dr. Mansoor and Dr. Das to stay back. But I will request Dr. Mansoor Ahmed and Dr. Abdul Rashid Khan and Dr. Ashokan to come back after 15 or 20 minutes after the coffee break to join the next session. You have the scientific program with you. Thank you. So we have the coffee outside on the first floor. So all the people who are here may quickly go there and within 50, what is the time now? 11:53, we are already late by half an hour. So we'll start exactly at 12:10. 12:10, we'll start back and Dr. Vanita Arora is here, so it's nice to, so we'll have starting the next session at 12:10 and a small delay about 20 minutes is already there. So we'll be happy to have a quick coffee, myself going there, and then we'll come back quickly.
Recording stopped.